Welcome, everyone. Thank you so much for joining in today for another of our seminars in neuropsychiatry talks for this year. It's a great pleasure to welcome you all, and I think it's an exciting year with our talks and then also the International Neuropsychiatry Group talks that have been running that I'll share some details in the chat. And it's a wonderful pleasure to have Professor Perminder Sachdev join us again. Today he spoke, had a wonderful and well-attended talk last year. So many of you will know and have heard of Professor Sachdev, who's a co-director of the Centre of Healthy Brain Aging at UNSW in Sydney. He's clinical director of the Neuropsychiatric Institute at the Prince of Wales Hospital. And he's co-chair of ADNET, the Australia Dementia Network, and also director of the Centre of Research Excellence in Vascular Contributions to Dementia. He's published over 800 journal articles and 6 books. His major areas of research are in drug-induced movement disorders, an expert, and really looking forward to your talk today on this topic, as well as brain imaging, cognitive aging, dementia, and a broad range. And also as a book, The Yipping Tiger and Other Tales from the Neuropsychiatric Clinic. I've just got my second copy that arrived the other day. Other awards: he was appointed member of the Order of Australia for services to medical research, and also in 2010 named the New South Wales Scientist of the Year for Biomedical Sciences. In 2018 won the Darf Ugelbar Innovation Award for Dementia Research. So thank you, Brenda, for taking a time out of your busy clinic today to talk to us, give us a very current status of tardive dyskinesia, a very important topic and relevant to all of us here. Thank you.
So thank you so much, Tamidu. And I can see some familiar names, that not many familiar faces, because mostly it's only names. It's lovely to speak to you about tardive dyskinesia. I think a topic that to some extent has been forgotten. And I think the younger generation of psychiatrists are not familiar with tardive dyskinesia to the extent that we were when we were training, which was actually, it was bread and butter psychiatry in those days. So let me just begin by just saying that there are no conflicts of interest here. Now, I take it that you're either psychiatrists or trainee psychiatrists, so you're already familiar with tardive dyskinesia. So I don't need to go through the basics. Essentially to say that the word tardive means delayed onset, and dyskinesia is a generic term for abnormal movements. And most of the movements that we will be talking about in tardive dyskinesia are choreiform. They're more like fast movements or slow writhing movements, which are athetoid, and often they are combined in dyskinetic movements, so that we call them choreoathetoid movements. But then you would also see some dystonic movements, and dystonic movements are slow movements which are sustained at the maximal peak of contraction. And we will see some examples of that if we can run videos. I have a problem with the videos because I've changed computers, unfortunately, at last minute. So it may not run. Then some stereotypic movements and a combination of these movements. So this is really what the range is in tardive dyskinesia. And because of this range, we have 2 groups within the camp, really. We have the lumpers and the splitters. Some people would put all these as part of tardive dyskinesia, but others would say that no, there are probably sub-syndromes within tardive dyskinesia. There is the classical tardive dyskinesia with the choreoathetoid movements, and then you have other descriptors such as tardive akathisia, tardive dystonia, tardive tics, and even tardive Tourette's, myoclonus, tremor, and tardive Parkinsonism. And you see examples of all of this in the literature. And there is some relevance, in fact, in terms of these subsyndromes, because firstly, the manifestations are slightly different. And secondly, the pharmacological profiles of these subsyndromes may be slightly different. So the way we treat tardive dystonia is slightly different from the way we treat tardive dyskinesia. So it is relevant to possibly look at these subsyndromes. Now, even within tardive dyskinesia, there are 2 subsyndromes described. There is the one classic OBLF syndrome, where the movements are largely in the ovobuccal lingual facial musculature. And then you have the limb truncal syndrome, where the movements are largely in the limbs and the trunk. And you tend to see the OBLF syndrome more in older people. Whereas in younger people, you may see more limb truncal movements. But that's a generalization. And often they co-occur, really. You have movements. People with orolingual buccal movements also may have movements in other parts of the body. In fact, any part of the musculature can be involved in tardive dyskinesia. So I think this is a broad framework in which we'll be working. Now, there are a few things about the movements in tardive dyskinesia that I'd like to emphasize. Firstly, as I mentioned, the OBLF musculature is the most commonly affected, but any striated muscle may be affected. Now, often one of the first symptoms that you see is movement of the tongue sitting at the base of the mouth. In fact, this is what I do when I examine a patient with suspicion of tardive dyskinesia in early stages. Ask them to open their mouth with just the tongue sitting. Don't ask them to protrude the tongue necessarily. The tongue sitting at the base of the mouth. And you see this vermicular movements, like riding kind of a movement of the tongue, which is not a tremor of the tongue, because tremor of the tongue is also commonly seen in many patients. So you have to distinguish a tremor from a riding kind of a rolling movement of the tongue inside the base of the mouth. And that's often an early feature of dyskinesia. The movements fluctuate over time. And that is one of the things that you see, that you may see 1 week you have a patient, you witness movements, but then you see them the following week and there is no movement. And the dyskinesia hasn't gone away, it just fluctuates. And that's why often you see some report from the family that yes, they are concerned about movement, but you may not see that on the examination. So generally you bring them back to examine them another time. There are changes with under certain circumstances with emotional arousal, and some distracting tasks often increase the movement. So often we ask them to say tapping fingers is one distracting task, or you may ask them to count mentally, and even doing an activity like protrusion of the tongue. Sometimes we bring out movements in other parts of the body. But in fact, when they are actually engaged in activity with a particular part of the body, that doesn't show movement so much, really. In fact, action sometimes will suppress the movement. For example, they have choreographed movements in the fingers. When they're actually doing a task with their hand, the movements may not be seen. So that's something that you have to remember, that often the distracting task may bring out general movements, involuntary movements on the parts of the body. So you examine them as a whole, really, not that particular part of the body. And often with relaxation, movements decrease. Usually in sleep, dyskinetic movements disappear. Occasionally, patients may say, look, they have movements in sleep as well, but that's very unusual. Usually they disappear. Now, dental status will worsen orolingual movement. So you often ask the person if they have any problems with their dentition. Ask them whether they're wearing dentures, the ill-fitting teeth or dentures inside that need attention. That we think that may be a mechanical effect sometimes in the movements, but also poor dentition is another marker of either poor health generally or an accelerated aging process, which may be a risk factor for dyskinesia. So that may be the association from a different perspective as well. Patients may be unaware of their movement, especially if it's orolingual movements or mild, say, choreographed movements of the fingers. They may not be aware, and others may notice the movements rather than the patient. The patient may be unconcerned in many cases. And the other thing we say about tardive dyskinesia is that even though we believe that the antipsychotic drugs that we're giving them are etiologically causative, but the drugs also suppress the movements. So what you can do is you can increase the dose of the medication and the movement is suppressed. It doesn't mean that dyskinesia has gone away. It's just become covert rather than overt. And if you then take them off medication, the dyskinesia will often reappear. And often that's called a withdrawal emergent dyskinesia. If it's happening for the first time, that's when you first see the movement. Now, but that response to antipsychotics is, of course, variable. Not every patient responds in the same manner. So in fact, that's why it leads to some kind of terminology. When do we say that person definitely has tardive dyskinesia? In research, we generally say, okay, they've had at least 2 examinations, maybe a few weeks apart. And dyskinesia is present on both occasions, we say that's definite. And when do we say, is it persistent? And persistent dyskinesia, generally in research, we use 3 months. The dyskinesia has been present for 3 months. And the reason for that being that if the onset of dyskinesia is upon withdrawal of medication. So if the patient was completely well, and you said, okay, let's withdraw the antipsychotic medication, and there was no dyskinesia prior to the withdrawal, dyskinesia appears for the first time when you withdraw the medication. Often that will get better within the first 3 months. And if it persists beyond 3 months, roughly, then the likelihood is that it may become persistent, may go on for a long period of time. Even though withdrawal still continues, improvement, remission still continues to occur, even up to a year, even beyond that, over several years, if the patient stays off medication. But the best improvement is seen in the first 3 months after withdrawal of the medication. And that's why you probably can talk about a masked or covert tardive dyskinesia, where you actually have increased the dose of medication or dopamine blockade, and the dyskinesia is suppressed by that. And in the good old days, antipsychotics were often used for treatment of tardive dyskinesia as well, paradoxically, because of course patients will at least temporarily improve until they get a breakthrough dyskinesia, which can be even worse than the original one. And I've already talked about withdrawal emergent tardive dyskinesia. So these are the kind of terms that you'll come across in the literature when referring to tardive dyskinesia. Now, how common is it? Now, if you look at the first generation antipsychotics, and these are all, as you can see, studies going back a few decades. Let's look at this study from New York, Kane et al. They followed patients over 7 years. These patients were started for the first time on antipsychotics and then were followed up. And they noted about 4% per year of incidence of dyskinesia. Then the 5 years, about 18%. So roughly 20%. And this is a study from Yale, Morgenstern, 1993. Similar kind of figures, about 5%. So 4 to 5% per year is the risk if a person is on first generation antipsychotics. And then if they've been on long-term antipsychotics, usually it's about 20 to 25%, even some studies, even 30%, but more 20, 25%. And then some people get better, some get worse. But overall, this is the figure that you see in long-term patients on antipsychotics. The exception is this study, Gesti et al. From San Diego. They had a risk of 20% per year risk and long-term risk of over 60%. And this is because these were older people. These are older veterans who had been started on antipsychotics for late onset psychosis. And certainly the risk in elderly is much higher, as you can see, several-fold higher. Now, what about the next generation, second generation antipsychotics? Now, here are the figures for the first generation antipsychotics, and the figures, as you can see, per year for second generation antipsychotics. These are data put together by Carbon et al. In 2018. So the risk is definitely lower. If you look at a summary of this, overall, in research studies, if it's a 1 year risk, 6.5% was the overall consensus data from these studies versus 2.6%. If you look at clinical studies where clinical examination, these are clinical patients, not actually research investigations, it was more like 4% versus 1%. So if 4% per year is what we say the first generation antipsychotics, but the second generation is closer to 1%. So certainly risk is much lower. but certainly not negligible, certainly not absent. I think that's one thing that you remember, that the second generation antipsychotics, even though our emphasis in the second generation antipsychotics has moved to looking at cardiometabolic side effects and other side effects, but the problem with movement disorders has not gone away. And I think that's the lesson perhaps to take from these data. So here you're saying, talking about incidence and clinical stress, and overall prevalence, long-term prevalence, if it's about 30% from this analysis, Correll and Schenk, it's about 13% with the second generation antipsychotics. So if you look at the ratio versus first generation antipsychotics, so the different commonly used and second generation antipsychotics, you will see that amisulpride and aripiprazole probably comes out in front as probably having one of the lower risks, certainly not absent, but certainly quite a low risk. And then amisulpride and olanzapine probably. In fact, when you look at risperidone, and in fact data on quetiapine is surprising, but it's not much lower here relative to the first generation antipsychotics. But certainly I think overall, I mean, this analysis, I think it's not consistent with some other studies which suggest that the risk is lower, but certainly the risk is there with quetiapine. And I think that's one reason that I worry about the way quetiapine is used as a hypnotic very often, and often it's used in older people as a hypnotic sedative, which is not, I think, a great strategy that many GPs tend to use Seroquel so commonly. The question which is in dispute is about clozapine and the risk for tardive dyskinesia. And we will come to that later as well. And the reason being that problem with clozapine is that most of these people, when they're put on clozapine, have been on several different antipsychotics prior to having been treated with clozapine. And that's why you don't get a clean picture here with clozapine. We have seen, maybe I've seen one or two cases where I thought clozapine was primarily responsible for tardive dyskinesia. But overall, generally, we tell our patients that clozapine doesn't have risk of tardive dyskinesia, and that if you're going to switch you to another drug, if you have tardive dyskinesia and need an antipsychotic, if you're going to switch you to another antipsychotic, clozapine is probably the best to switch you to. And we'll come to that as to what happens when you switch someone to clozapine from another antipsychotic. Okay, so let's look at risk factors very quickly. So age, as I said, is a risk factor. And age is a risk factor for a number of things. One is the incidence is much higher, as we saw from that study. The severity is greater, and also tardive dyskinesia is more likely to become persistent in older people. In fact, the thing that you remember is that in older people, even exposure of a few weeks may be enough to give tardive dyskinesia. So even when you actually use antipsychotics, I think you should try to stop them as soon as you can, and not just keep people on antipsychotics. Now, in terms of sex, there been some studies that there is a female preponderance, but perhaps in older people, older women may be more at risk. Although the literature is not totally consistent on that, but there is an age-sex interaction. And we say older women probably at greater risk. Now, in terms of the primary psychiatric diagnosis, there is some evidence here that the primary disorder may have some relevance here. Within schizophrenia, we think people with a negative syndrome, with more deficit kind of symptoms, are more likely to have tardive dyskinesia. Mood disorder patients are more at risk for some reason, and people with some organic brain disease, say either maybe intellectual handicap or dementia or some other brain disease, are at greater risk of TD. Now, as far as the drugs are concerned, we already know that type of drug, like first generation drugs are more likely to cause tardive dyskinesia, and also high potency drugs, perhaps more so than low potency drugs. And dose is important. So this was a dispute in the literature for a long period of time that we didn't have good evidence, but dose and duration are important. So high dose and longer duration, and even a person who has been on antipsychotics for 5 years or 10 years and haven't developed tardive dyskinesia doesn't mean that their risk has gone away. They still may be at risk, tardive dyskinesia. But there is a hand up. I don't know whether we should take questions. Dean, would you like to ask something? Oh, okay, never mind. And the other question has been in the literature is, okay, how do you reduce the dose? So one strategy that used to be quite popular in the past was to give drug holidays to people. So you take drug only for 4 days in a week or 5 days in a week. We don't think that that strategy necessarily is better. And animal studies have shown that these kind of drug holidays do not necessarily help, although animal studies do not easily translate into human work here in this field. But we don't recommend drug holidays, and the risk of relapse does go up patients who have drug holidays. The other thing is the patients who develop acute extrapyramidal side effects or acute akathisia to a severe degree may be more at risk down the track. Really, there's some studies suggest that may be an early sign that this person may be more at risk. Now, as far as anticholinergic drugs are concerned, anticholinergics do not themselves cause dyskinesia, but they worsen the manifestation of tardive dyskinesia. So patients with TD, we take them off anticholinergics. Unlike drug-induced Parkinsonism, which responds to anticholinergics, TD does not. In fact, TD becomes worse with anticholinergics. So the idea is to take them off. Lithium, we do not think causes tardive dyskinesia. Rare reports of lithium-induced dyskinesia can be seen in literature, but it's not been very convincing. Right? We don't think lithium is a risk factor. In fact, the animal literature suggests it may be protective, but overall we don't use it in that sense, but we don't think it's a risk factor. And tricyclics, SSRI, there are occasional reports of dyskinesias with SSRIs and tricyclics. And I've seen some cases, but this is very rare. Generally, we tell patients, look, we do not think antidepressants cause tardive dyskinesia, with the rare exception. There are some host-related factors: smoking, diabetes, alcohol abuse, ill-fitting dentures, etc., dental status. We talked about that. Ethnicity may be a factor, but nothing. I mean, America, Black communities have been noted to be at high risk, and I think there are, some reports of Asians having a differential risk as well, but nothing in terms of genetic factors. A lot has been written, but mostly these are candidate gene studies. Some genome-wide association studies as well have been done, but nothing at this point. We don't have a polygenic risk score for tardive dyskinesia, so we don't do genetic studies. Some people do pharmacogenetic studies, and especially with a focus on this 2D6 P450 family gene, but in terms of poor metabolizers, in trying to see whether we can reduce the dose. Some people do that, but I generally, I'm not convinced that really that necessarily is the right strategy, because essentially your focus is initially when is treatment of the psychosis itself, the optimal treatment, the schizophrenia or mood disorder, as you can see, and not in terms of tardive dyskinesia. So it's not something in my practice. Now, what happens, say, if a patient has developed tardive dyskinesia? Now, the first thing, as I already said previously, if it is a withdrawal emergent dyskinesia, a majority of patients improve if you can keep them off antipsychotics. So don't panic. Tell them, patients, let's see what happens. Now, there have been occasions where it's been so severe, the withdrawal emergent dyskinesia was so severe that we put the patient back on antipsychotics. they were stopped suddenly, and then we withdrew them very slowly over a longer period of time. But generally, that's again the exception. Mostly we just wait and watch and say, let's see what happens for the next 2-3 months. And generally it gets better, but some will become persistent. Now, if it is persistent dyskinesia, it doesn't necessarily stay the same. It fluctuates, and many patients improve over time. And that fluctuation happens even if they are maintained on medication. Not everyone maintained on medication after developed dyskinesia gets worse. There are a few patients who do get worse progressively, but the majority do not get worse. They continue to fluctuate to some extent. So in fact, that's one of the things that we are in a dilemma. Often if a person develops dyskinesia and they need an antipsychotic medication, what do we do? And we will talk about that. What is the strategy today? But they don't necessarily have to be taken off medication. But the chances of recovery are best if they can be taken off medication completely. But if they cannot be, if their psychosis does not permit that to happen, then they could be maintained. What you try to do is give them the most favorable dose and the most favorable drug for that purpose. And we'll come to that in a moment. Now, what about when you confront a diagnosis of tardive dyskinesia? How do we can see some questions in the chat. I'll come to those subsequently, but let me just go through this. Now, there are some patients who develop acute dyskinesias. Sometimes they are caused by antipsychotics, which are look very much like acute tardive dyskinesia. Usually they will respond to dose reduction or stopping the medication. But there's another syndrome called the rabbit syndrome that you might see. Sometimes confused. I've been sent a few patients. Patient has developed tardive dyskinesia when it was actually a rabbit syndrome. Rabbit syndrome actually is a tremor of the lip, like we've seen a rabbit lip go like this. That's and it's a tremor. It's not a dyskinetic movement, and it will respond to anticholinergic medication. You don't need to stop the medication for that. Now, there are dyskinesias due to other drugs. Patients may be on phenytoin and carbamazepine. Our patients may be getting these stimulants, and dopamine agonists can cause dyskinesias. As I said, very rarely lithium and tricyclics have been reported that can cause, and anticholinergic antihistaminics, usually not. But sometimes with levodopa, with stimulants, with SSRIs, these dyskinesia may be delayed onset. So it could be, by definition, a tardive dyskinesia with these drugs also. But it's unusual. But for dopa, of course, with patients with Parkinson's disease treated with levodopa, often they develop dyskinesias later on in their illness, which is both their illness as well as the medication, both contributory factors to this. Now, also remember that dopamine antagonists used for other purposes. Say, a person is being given metoclopramide for a long period of time, then they may develop dyskinesia. And patients, I had one patient who had hiccups, and he was being given trifluperazine, very small dose, but for several years. And he came with quite severe tardive dyskinesia to me. He had no psychiatric disorder otherwise. So you don't have to have a psychiatric disorder. If you're being given antipsychotic or dopamine antagonist for any other reason, then you can develop dyskinesia as well. And of course, we see movement disorder in neurological illnesses, Huntington's, Wilson's disease, Sydenham's chorea, Tourette's, basal ganglia infarcts, autoimmune diseases, endocrine problems. These come in the differential diagnosis when you have an atypical presentation for patient. Patient develops dyskinesia very early in the illness, or they present initially with dyskinesia and maybe some psychiatric manifestations. Then it comes in the differential diagnosis. Now, also remember that patients develop spontaneous dyskinesia, especially older people. And these have been prevalent. data suggests in the 6th, 7th, and 8th decades, you see spontaneous dyskinesias. These are people who haven't been exposed to antipsychotics at all, really. And people with dementia often may have dyskinesia. So that's something to consider a differential diagnosis. But if the patient is on antipsychotics, of course, you have to attribute at least a contributory factor, if not a primary factor. And that's why we think in older people who are already vulnerable to dyskinesias, these drugs may bring out that vulnerability to a much greater degree. Now, does dyskinesia happen in psychiatric patients without antipsychotics? In fact, there was at one stage there was a controversy that people said, "Oh no, it's not the drugs. These people would have developed dyskinesia in any case." If you go back to the pre-drug era, say going back to the early 20th century or the 19th century, there were description of dyskinesias in many psychiatric patients, and there were no antipsychotic drugs in those days. Yeah, but the literature on these is very confusing, really, because very often what is considered dyskinesia would be posturing, catatonic movements, or repetitive movements. And often these people they were sitting in mental hospitals, bored, they have repetitive movements, or they may be quite catatonic. And they were all part of that, they considered as dyskinetic movements. So it was really very confusing literature when you actually review it. But there have been some good studies in first episode, and in particular this study, the Chatterjee et al., again from the New York group. They looked at spontaneous dyskinesia at first onset. How many people had dyskinesia prior to introduction of medication, and different reports you can see here. But definitely when these guys followed these people up after starting medication and looked at placebo control, there was a clear difference. So there's no question that drugs are a major factor in this, really. But of course, drugs work on a substratum of vulnerability. And that's why not everyone gets it. And of course, and what kind of disease process you have may also influence why one person may develop it and not enough. So in terms of laboratory investigation, you see when you look at the differential diagnosis, this is, if it's an atypical presentation, this is what I would generally do in terms of a workup. And that's a reasonably comprehensive workup to kind of rule out the differential diagnoses. Of course, you do a good examination and look at other aspects of this as well. Okay, so then of course, you want to rate the severity of dyskinesia, and the most commonly used scale is the AIMS scale, the Abnormal Involuntary Movement Scale, which has been around from the 1970s. And it actually rates the dyskinesia in 7 body parts, 4 craniofacial, upper limb and trunk, and then the lower limbs, and rates on a 0 to 4, with 1 being minimal, like you're not sure, maybe it's present, and 2 is mild but definitely present. And then you give a overall rating and also do a severity rating. And you also know if they have a problem with their dental status as well. So this has really been the most commonly used rating scale, but there are several other rating scales available. There's an AIM examination. You can actually Google it, and there's a video for an AIMS examination. You can probably still find it on the web. We recently developed what we call the Unified Drug-Induced Movement Scale, essentially because we find that often TD is not the only movement disorder present in these people. They also have a tremor, they may have other extrapyramidal symptoms, they may have akathisic symptoms, and may have dystonia, myoclonus, and you don't have to have 5 scales being rated one after the other to capture the full. So we came up with this Unified Drug-Induced Movements. We sent it for publication, but it's available on the medical archive. If anyone is interested in, you can get it. You can Google the medical archive. You can actually search for the UDIMS or search with my name, and you'll be able to get this. So essentially, the scoring system is very similar, but the description as to how you score these various movements is there in some greater detail. And we are encouraging people to use the UDIMs now as maybe one unified scale with sub-syndromes that you can either collapse or you can separate them out as you require. Okay, now why does tardive dyskinesia develop? And the pathophysiology has been disputed for a long period of time, and still we do not fully understand. And there are many complications with TD which makes it difficult. The most popular hypothesis has been the dopamine supersensitivity hypothesis. And essentially that hypothesis says that, so we have, this is the dopamine terminal, and you have, say, the presynaptic terminal here, and postsynaptic dopamine receptors here. Dopamine is being released, and of course, then it starts off the postsynaptic processes here. And what you do with the antipsychotics is you block these dopamine receptors. So as a consequence, what happens is that as the body, there's a feedback system, and therefore the body, the presynaptic terminal will pump out more dopamine to overcome the blockade. Yeah, and the other thing that will happen is that there will be sprouting of new receptors here. So this postsynaptic terminal becomes hypersensitive, really, or supersensitive to dopamine. So basically, that's the homeostatic response, and that'll happen in the nigrostriatal pathway. It'll happen in the mesolimbic pathway as well. So when you, but you block these, even supersensitive receptors. So when you take them off, you have a hyperdopaminergic state. You have a lot of, you have increased number of receptors here, and you have the dopamine being pumped out. You will therefore see increase, and that increased dopaminergic activity is what is the hypothesis is manifesting as your abnormal movement. So when you actually increase your blockade, you pump in more drug, you block this further, you can suppress that movement. So that's really why you see withdrawal emergent dyskinesia. And that's why blockade, any dopamine blockade will lead to this kind of super sensitive state. Dopamine. The problem with this is that when you actually look at an animal model, this super sensitivity happens very quickly. Even after one single dose of an antipsychotic, it will happen. And then it reverses when you stop taking it. After a while, the supersensitivity go down. But in humans, we see that tardive dyskinesia doesn't happen within a few days or within after a few doses. It happens after a long period of time, often months, years after the person has been. So what has been going on in this period, really? If it was just dopamine supersensitivity, that happened a long time ago. So something else is happening as well. Dopamine supersensitivity is happening, and there is some evidence in humans that it is happening as well, as just as an animal model. We can show that it's happening. But there is something else happening, which is making it not only delayed, but also persistent. And why dopamine supersensitivity happens in everybody, but only some people go on to develop tardive dyskinesia. So there is something else additionally happening. There have been other hypotheses that have implicated noradrenergic, cholinergic, GABAergic systems as well. But the dopamine, of course, we know that dopamine antagonism is really the major factor in producing tardive dyskinesia. So D2 antagonism is a key factor, definitely here. But what we think is happening is that there are downstream effects of that dopamine blockade. And one is that as I said, there is increase in dopamine turnover. And when you actually metabolize dopamine, you have increased production of free radicals. So there is oxidative stress. And because it is largely happening in the striatum, and these GABAergic cells are particularly vulnerable to that oxidative stress. So we think there is loss of these GABAergic cells. So there is some morphological change happening as well within the striatum. And we think that may be the reason why it can become persistent, really. So these are inhibitory cells, so you're knocking them out. And that may be the reason that you are producing increased activity in that circuit, in the abnormal circuit, in that cortico-subcortical circuit that underlies movement, and that may be the basis. And because these cell loss may be permanent, you may have persistence of tardive dyskinesia. So we think that both things are happening, possibly. That there is dopamine supersensitivity. So some aspects of TD can be explained by that, but also there is some structural change, and as a consequence, change in the cortico-subcortical circuits, which may be persistent, even though the body still tries to repair it, but it may not be able to do that. So what you want to do is minimize that factor. I just put out this slide as genetic factors, but we've already touched upon this. There is an effort towards coming up with a multi-gene panel for TD, but at this point, we don't have one. So that brings us to the treatment. And the message that I want to convey is that we do not have effective treatment for TD. We have some drugs that suppress the movements, but they are not therapeutic in terms of producing total recovery from the disorder. So prevention is the best strategy. And in terms of prevention, think of prevention when you start a patient on antipsychotics. That is the point to start. Restrict the long-term use of antipsychotics to well-defined conditions, and do not willy-nilly put people on long-term antipsychotics. Even bipolar disorder patients with depression, I think there is a tendency with recurrent depression as well, tendency to put people on drugs like olanzapine or quetiapine long-term for mood disorders, with this notion that because they've been marketed as mood stabilizers by drug companies. I think we have to be careful in doing that, and use non-neuroleptic, non-antipsychotic drugs for agitation, insomnia, etc., and use antipsychotics at the lowest effective dose for the shortest period possible. Of course, we want to effectively treat the primary psychiatric disorder. There's no question about that, but try to see what is the best, the lowest dose you can give. And of course, we recommend using second-generation drugs now as first-line drugs. And assess the patient's risk factors, alcohol use, smoking, diabetes, etc., and anticholinergic drug medication, as I said as well. And then, of course, evaluate the patient regularly, and also consenting the patient. I think that's the other issue, which is often difficult, because when we start patients on antipsychotics, often they're not in a position to give you consent. But consent is not a one-off process, really. As you see the patient over a period of time, you engage the patient and try to make them understand what the drug is for and against, really. Of course, there are situations when you're not able to, when the patient has very little insight, and you confront them. Then, of course, it's your responsibility to monitor and see that you're offering the best patient treatment for the patient, considering the dilemma of choosing between psychosis and TD. Now, in terms of management, if patient has antipsychotics, has tardive dyskinesia, is on antipsychotics, then you say, okay, revisit the diagnosis, see, do they need antipsychotics continue? Can we use alternatives? Can we put them on mood stabilizers? Is mood stabilizer enough for them? And if not, no, are we using second-generation antipsychotics? And within that, second generation of psychotics, there may be some differences, like risperidone may be at increased risk, as opposed to amisulpride or aripiprazole or quetiapine. So there may be some maneuver there. Of course, you don't want to destabilize the control of the patient's psychiatric disorder either. So it's a kind of a judgment call very often. Attend to patients' dental hygiene, and of course, education and consent come up again. And certainly something you note down in your notes that you've attempted to provide this consent and why you think antipsychotics should be continued. Now then, of course, you've done all that, and you still have a patient with tardive dyskinesia, and you, even if you stop the medication or you patient still continued on the optimal medication, how do you treat them? And the drugs we are talking about are drugs to reduce the manifestation. They're not a cure. And they will work only as long as you give them. And the drugs often, drugs you can use, as I said, you don't want to put them on another antipsychotic just to suppress the movement. But you can actually reduce, working on that dopamine supersensitivity hypothesis, if you reduce the level of dopamine in the brain, you may be able to reduce the dyskinesia. But you do that with not more dopamine blockers, but you use VMAT2 inhibitors. And there are 3 drugs now currently available worldwide, but we have only tetrabenazine. We don't have the other deutetrabenazine, valbenazine available regularly. We can maybe access them through a special access scheme, but they need to be imported, and valbenazine needs to be imported. And you have to consider. So I'll talk about the VMAT2 inhibitors, because there's a lot of talk about these in the literature now, because these are 2 of these drugs are only recent drugs. Tetrabenazine has been around for a long period of time. And what do they do? What VMAT2 inhibitors do? Now, as you know, in the presynaptic terminal, the neurotransmitters are in these vesicles. And these vesicles are the ones when you have an impulse come through, they fuse with the membrane, and the transmitter is released, like dopamine is released. Now, and then dopamine is taken up by the dopamine transporter back, and then incorporated in the vesicle through this VMAT2. So it's a vesicle monoamine transporter 2, really. So what you could do is, if you knock out the VMAT2, the dopamine that's taken up by the terminal through the dopamine transporter will no longer be incorporated. Then it'll be metabolized by the monoamine oxidase here. So essentially, you're depleting the presynaptic terminal of dopamine, because much of the dopamine here is what is taken up from what is released, is recycled. So you're stopping that recycling. Anything that is manufactured from the beginning, from ab initio, will be there, but the recycling, you actually stop that process, and that's why you're depleting this. So you lead to a hyperdopaminergic state. And there are 3, as I said, 3 VMAT2 inhibitors available. Tetrabenazine has been available. It's available on authority for hypokinetic disorders. I've used it a lot of patients. Approved for Huntington's chorea by the FDA, but not for TD. But we use it off-label for TD. And in Australia, it is available for any hyperkinetic disorder. The dose I start with for 12.5 milligram BD, and then I go up. Usually, it's tolerated between 75 and 100 milligram a day, usually in divided doses, a couple of times a day. And common side effects are depression. It can cause Parkinsonism, drug-induced Parkinsonism, because you're depleting dopamine in the brain. And somnolence are the main problems with this drug. I find that patients don't tolerate it so well. Side effects are common. And that's why, but some patients do, especially older people. Sometimes even a small dose may work for them. And there have been trials with deutetrabenazine. Basically, you are substituting hydrogen molecules with deuterium, and you change some of the properties. And there have been some trials recently, as you can see here. If you look at success with deutetrabenazine 24 milligram per day, this is CGIC treatment success at 12 weeks. You can see that there is good response, 24 and 36 milligram relative to placebo. And there have been a few trials with valbenazine. You can see that valbenazine is another VMAT2. You can see the change here over 6 weeks, and you can see the change persists up to 2 years with valbenazine. So this is a kind of meta-analysis with deutetrabenazine with valbenazine. You can see overall, you can look at the effect size here, about 0.5 or so. It's not a huge effect size, but definitely a significant benefit to patients. And in terms of pharmacokinetics, I'm rushing this because I'm running out of time. You can see that valbenazine is a longer acting drug, but tetrabenazine is short acting. So you need to give them in divided doses. Okay. Now, other drugs you can see there's so many other drugs. What happens if this is not tolerated? VMAT2 inhibitor is not tolerated or produces side effects or doesn't respond. Then other drugs I tend to use are other GABAergic drugs. Clonazepam, there is some evidence for that. Often start with say 0.5 milligram or 1 milligram, but may have to go up to 3 to 4 milligram to produce a good response. Sodium valproate, baclofen have been used as well in some cases. Some case patients will respond. Levetiracetam has been used one study, but not. I haven't used it much because there are other significant side effects that this drug has. Keppra, it's an anti-epileptic drug you're familiar with probably. Amantadine may be useful in some cases as well. But as you can see that from the list of drugs, that none of the other drugs seems to work very well, and we often go down the list. But these are GABAergic drugs, or the second line drugs that I would tend to use. And then I switch some patients to clozapine, not only because clozapine I think is safe in terms of worsening the tardive dyskinesia. Some patients do respond. In fact, there are 4 studies, clinical studies, open label studies, showing a standard mean change of minus 2.56 and 12 studies, subclinical TD mean change in the AIMS score, really, which is quite significant. It's actually better than what you get with valbenazine or with deutetrabenazine. You can see compared to this is the change score with the VMAT2 inhibitors. So over time, we see patients get better when they switch to clozapine. So I often convince them to switch to clozapine. Now, there are other things that you could do. Botox is something, especially if there is one major movement disorder that is a major muscle group that is particularly troublesome, and also patients who have tardive dystonia. Tardive dystonia, I do use VMAT2 inhibitors sometimes, but I haven't seen much of a response in my patients. And sometimes tardive dystonia, I treat them with anticholinergics as well, unlike tardive dyskinesia, if it's only a pure dystonia. But you may need a high dose anticholinergic. But my experience, idiopathic dystonia responds to anticholinergic sometimes, but tardive dystonia, I haven't seen much of a response. Most of my patients go on to Botox if they have tardive dystonia. And Botox seems to work in producing good benefit usually for 2 to 3 months. They need an injection every 3 months or so. With antioxidants, there was a lot of excitement about vitamin E and other antioxidants. Overall, it's not proven, really. In fact, one large study was negative. And other studies, some people have given ginkgo, etc., but you can use them as adjuncts, but really the evidence is not so great. Cannabis, there's some study we are actually thinking of. We've been talking about a study as well with CBD. The evidence is not so good. There have been a couple of trials, and there's evidence for animal models and a couple of trials of CBD with or without THC. But at this point, it's just trial and error, really, if a patient will have it. Now, there's some heroic measures. You can, very severe dyskinesia, deep brain stimulation, pallidotomy, ECT have been used. And you can see the list of cases, number of cases with tardive dyskinesia using DBS in the literature with some response. But of course, this has to be very severe dyskinesia, very disabling dyskinesia, there's nothing else. So take-home messages before we finish. Consider the possibility of TD in any patient you start or maintain on antipsychotics. Recognize it early, admit the possibility that some of the patients have tardive dyskinesia. You may not be looking. You may not be examining them. Learn the AIMS examination and do it. If it's a long-term patient you're looking after, incorporate its assessment in your practice. Try to reduce the risk and prevention is best policy. Intervene early. Follow them if you're suspicious of dyskinesia, and do not use antipsychotics until it's clearly indicated, and use them judiciously, and be careful, especially in the elderly. So thank you very much. I'll stop here. There are lots of questions. We may maybe Damidu, you may.
Yeah. If I was going to check, I know you've got a busy day.
If you've got a few minutes, we can probably.
Oh, great! If you've got, maybe we'll sneak one question in. Thank you so much. A wonderful talk. Look, it's hard to choose, but I think the Carbonell paper seemed to stimulate a lot of questions. So the one I'm going to ask here is, so if you're looking at the data from that paper, if amisulpride and comparing it to clozapine, even quetiapine, should we be using amisulpride instead for treating TD, especially for people who can't, for various reasons, have clozapine? And also, how do we understand this if they're meant to have such different mechanisms?
Yeah, so it's a difficult literature to actually come up with definitive answers to that. So what I try to do is, if a patient doesn't want to go on to clozapine or cannot tolerate clozapine, then the drugs I would consider are aripiprazole, quetiapine, and amisulpride, really. And I'll decide, okay, which one of these is possibly the best for them, and what dose can we get away with to produce a good antipsychotic response. Yeah. So those are the drugs that, literature suggests that aripiprazole probably has the lowest risk, but I've seen patients on aripiprazole develop TD as well, and other drug-induced movement disorders. So it's not completely free of this risk. And the same with amisulpride. Nothing is free of risk completely.
I got a couple of questions about stimulants and tics. So one, any medication to manage stimulant-induced tics for ADHD? Will the VMAT inhibitors help? And someone's mentioned seeing patients who've developed blepharoplastic tics with aripiprazole. If you've got any suggestions.
So with stimulants and tics, my concern is to not try to treat with another drug, a drug-induced side effect with another drug. Now, in psychosis, we are stuck. We don't have better options, really. I think when we are treating with ADHD, you should certainly consider that you may be giving them more problems than solving them, really, by giving them another drug. Because the options we have is either a VMAT2 inhibitor like tetrabenazine here, which has a lot of side effects of its own, really, and it's generally not well tolerated. Or a dopamine antagonist, you're antagonizing the effect that you're producing with the stimulant anyway. So I would tinker with the dose of the stimulant, lower the dose, and also look at an alternative stimulant. Sometimes that may not be the best stimulant for this person. I generally try not to treat it with another drug, really, or use non-pharmacological strategies for the ADHD. So with the second question, was it blepharospasm? Is that what you're saying? That's
right. Yeah. I misread it as well. Yeah.
Blepharospasm with aripiprazole. Now, blepharospasm is it's a dystonia, and I have a number of patients with blepharospasm. Usually, Botox is what I recommend for blepharospasm as the best strategy, because as soon as you, again, said when you giving them a VMAT2 inhibitor, most of my patients say they have side effects, really. And of course, Botox can come without any side effects. Good Botox injection, often patients will not know anything after that, really, and they feel quite normal, really. So I think that is, if they need to be maintained on antipsychotics subsequently, then certainly they are patients. And I have some patients who've been taking Botox for several years. If it's very localized, and blepharospasm is ideal for that.
Maybe we've got one more question, Perminder, would that be okay?
Yeah, sure.
Great. So we have one here. So a patient's been on multiple antipsychotics over their treatment. Is there any sort of cumulative effect in terms of emergence and time types, those kinds of things?
Yeah, I think the evidence is there that it is cumulative. Yeah, and I think, of course, what researchers do is when they try to look at overall neuroleptic exposure or antipsychotic exposure, they convert them into chlorpromazine equivalents or something like that. So every drug is then converted into it. It's, of course, very hard to incorporate all the drugs into an analysis, into a logistic regression or whatever you want to do with your a mixed model kind of longitudinal studies. So you have to collapse it into some measure. And often chlorpromazine equivalence was a measure we used to use. And still, to some extent, that is used as one measure. And you see that, yes, the dose does matter over a period of time. Right? And being on one drug as opposed to being on several different drugs is an issue. That I don't think is clear if you take the dose into account. Because often people on several drugs have a cumulatively larger dose than on single drugs.
Right. Thank you, Perminder. Look, I think we should wrap up. There's so many other questions. I'm sorry we haven't been able to ask all of them. But Perminder, thank you so much again for coming to speak here at the seminar and for another fantastic, comprehensive talk with so much that we've, I think, take from this and food for thought and absolutely clinically relevant.